Start, sir. We are live.
Hello, good evening, everyone. Welcome you all for this live webinar, day 2, recent developments in common cancer treatments. For further proceeding, I would like to invite program convener, Dr. Divesh Goyal. Sir is senior consultant, medical oncologist, Fortis Hospital, Jaipur. So over to you, sir, for further proceedings.
Yeah, thank you, Aram, and thank you, Cancer Research and Aesthetic Foundation and Horizon team. And I think we started this virtual webinar on 6th, and yesterday we covered the lung as well as the genitourinary. So today is the day 2, and we will cover the breast as well as the genitourinary cancer in this ovary as well as the urothelial cancer, prostate, and cancer we will cover. So the aim of this conference is to cover all the highlights and recent trends and to use the recent trends and to applicable in routine to day-to-day practice. So without wasting time, I invite the first speaker, Dr. Aseem Samar Bose, who is senior consultant medical oncologist at Bhagwan Mahavir Cancer Hospital and Research Center, Jaipur, and he will present the data on Ascent trial. So I think over to you, Aseem Boss, for this talk.
Okay, thank you. So can somebody share my screen? I'm audible. Hello.
Yes, sir. Yes, sir.
Yes, sir, you're audible.
Yeah, please share the screen. Thank you, Dr. Devesh, for giving me the opportunity. And we are mutual friends.
Yeah, definitely.
So it is a short talk. I guess it is 15 slides only. First 2 slides are disclaimer and all that. So topic of my talk is Ascent trial, patient subgroup analysis of sacituzumab govitecan versus single agent chemotherapy in metastatic TNBC after 2 prior lines of the chemotherapy regimens. As we all know, in the metastatic setting in the TNBC, treating patient is very tough because initially response rate is very high if you talk about the NCT setting or adjuvant setting. But if you are trying in the metastatic setting, the patient is not de novo, it is de novo. After a few lines, the patient get exhausted and the you can say the response rate is very low. So always we find a difficulty in treating this kind of the patient. So everyone wants to know what best we can do with this kind of the patient, and generally we could feel like patient may survive less than 2 or 3 months after having the metastatic sites involved more than 2 or 3, and patient is not responding to the other chemotherapy regimens. And the other thing is chemotherapy regimen after 2 lines are very costly also. So TNBC is always a tough population to treat, especially after first or second line. So what happened in this Ascent trial? So they have tried one antibody drug conjugate, that is a sacituzumab govitecan antibody drug conjugate, and it was consisting of anti-TROP2 antibody. TROP is the receptor found in the cardiac cell also, myocyte also, and in the tumor also. So anti-TROP2 antibody conjugated via the hydrolyzable linker to the topoisomerase 1 inhibitor SN38. And this is very common linker and the topoisomerase 1 inhibitor SN38, which we had seen in the TDM1 also. And FDA approved indication for sacituzumab govitecan, we will call it SG. Sacituzumab govitecan include treatment of adult with unresectable locally advanced or metastatic TNBC, previously treated with the 2 prior lines of the systemic therapy. So we can very well feel that this kind of the tough population they have included in the trial. In April 2021, FDA granted regular approval to SG in this TNBC setting based on the Ascent trial data. Okay, and it was the phase 3 trial. Current subgroup analysis of the Ascent report and efficacy and safety of the sacituzumab versus chemotherapy among those aged less than 65 and more than 65, those in second line setting and TNBC recurrence more than or less than 12 months. Next, please. Next, can somebody change the slide? Okay, this was the schema design, trial design. So it was international and open phase 3 trial. They have included the patient with metastatic TNBC who had exposed to the 2 lines of the chemotherapy, but there was no upper limit and could include the progressive disease within 12 months of the neoadjuvant chemotherapy. Prior taxane should they have received, and RECIST criteria should be applicable. There should be measurable lesion, and they randomized into 1:1 patient, and permitted the brain mets if they are stable. So generally, we had seen TNBC has a higher tendency of having brain mets also, as we all know, and they have included the patient if the patient was stable. And PS01 they have taken, and the quite a large number of population in this post 2-line setting. They have enrolled, it's 529 patient. So sacituzumab govitecan given in the 10 mg per kg dose on day 1 and day 8, like we give eribulin in this kind of setting. Physician choice of the single agent chemotherapy, and they are equally divided 1:1. So what were the physician choice therapy? Was capecitabine, eribulin, gemcitabine, and vinorelbine, which very quite standardly we have used, and we want to use that. So it is 21 days cycle, and they have given. So primary endpoint was PFS, and secondary endpoints were the investigator assessed PFS, OS, ORR, and the time to treatment failure and safety. So trial halted early based on efficacy per unanimous recommendation of the data monitoring committee. Next, please. So as the international trial always have a good quality control, and they divide the population in both the arm very rigorously. This is well-matched trial, so every aspect they have taken out, and both the groups are very well matched and balanced. So baseline characteristic of those age more than 65 years comparable to the overall population. Chemotherapy used in those age more than 65 years are eribulin is 46% of the patient, vinorelbine 22, gemcitabine 22, and capecitabine 11%. So this is the very standard we use nowadays. Next, please. Next slide. Okay, this is the most important slide of this presentation. So let me remove this. So ASCENT subgroup analysis, PFS in patient without brain mets age less than 65 versus more than 65. So in this orange line, you can see this is a control arm, this is a chemotherapy arm, single agent, and it is the sacituzumab govitecan. You can very well see there is a great difference. P-value was highly significant in this population. P-value was 0.0001. Though you can see the median PFS in the months are very, you can see that difference is not much. But if you compare in the times, like it is 3 times. So it is 4.6 month PFS in the sacituzumab arm versus the chemotherapy arm. It was 1.7 month only. And hazard ratio is impressive. It is 0.46. It is very impressive in this particular setting. If you go by BICR analysis, and this is PFS, you can see it was 7.1 month, and in the chemotherapy arm it was 2.4 months, right? And the hazard ratio was 0.22. So it clearly showed like it has a great impact in the PFS. Next, please. Next slide. We will move fast, otherwise the whole conference, the webinar will be next. Previous one, will you please? Previous one. Yeah. So this is the overall survival data without brain mets, age less than 65, more than 65. In the oral survival, you can see in the sacituzumab arm, it is 11.2 months versus 6.6 months in the chemotherapy arm. And the p-value is again significant for the overall survival, 0.50. That means almost 50% patients had benefit with the experimental drug. P-value was 0.0001. And here it is also in the both the things it is significant. Next, please. Next. Okay, this is again the tabulated form of the previous one. If you can see patient less than 65, more than 65, CR rate, it was in the 4% of the patient, and PR rate was 28% of the patient. In chemotherapy, it's very hard to see CR in the 3rd line setting, and PR is also in 5% only. If you see in the more than 65, the PR rate was 7%, CR rate was 7%, and here it is 43% PR rate. None of the patient in the chemotherapy arm which were more than 65 got the CR or PR. So median duration of response was 5.8 months in the less than 65 years of the age, and more than 65 it is 7.1 months. Among those aged more than 75 years, 2/7 receiving SG achieved a best response of PR, or 0 out of 11 receiving the chemotherapy achieved a response. So out of 11, there were no response in the chemotherapy arm. So safety safety of this particular drug. So grade 3 reaction happened in the almost 73% of the patient, leading to dose reduction 19 and leading to a study drug discontinuation. They will happen in the 5% of the patient. This is, I guess, we have not used much, so we can't comment on that. But maybe in the real world scenario, discontinuation rate may be high, because we had seen in the other antibody drug conjugates, they are actually practically we have the higher discontinuation rate. But for the trial sake, it was only 5% patient were discontinued. Okay, one death observed due to the treatment-related adverse events, neutropenic sepsis related to AE, related to the eribulin. In the SG arm, numerically higher rates of the grade 3, but they said like it was manageable. Next, please. So efficacy of the SG versus individual chemotherapy agent patient without brain mets, we had seen in the graph. Next, please. Next slide. Okay, the safety profile of the individual chemotherapy agent were consistent with the overall chemotherapy arm. One treatment death occurred in the chemotherapy arm because of the neutropenic sepsis. As compared to the 0, but there were no death in the cetuximab arm. Discontinuation rate due to the treatment-related adverse events in the SG was 5%, eribulin was 2%, vinorelbine was 10%, capecitabine 7%, gemcitabine 9%. So in the commoner drug, it is less than the chemotherapy arm. Concomitant GCSF use for neutropenia was higher with the SG as compared to the chemotherapy alone, single agent. Next, please. Actually, chemotherapy drug conjugate have chemotherapy that is targeted by the linker and the antibodies, but they have the chemotherapeutic effects. That is a fact. And you can see SG versus chemotherapy in patient with the recurrent TNBC after recent or near-adjuvant chemotherapy. So median PFS in that particular subgroup was 5.7 versus 1.5 month. Hazard ratio was 0.41. And median overall survival was 10.9 months in the cetuximab arm versus the 4.9 months. So again, the p-value of that was significant, and the hazard ratio was 0.51. That is very impressive. In this exploratory subgroup analysis of the patient without brain mets, those TNBC recurs within 12 months of the neoadjuvant therapy and were previously treated with the first line of the therapy for metastatic disease, as they demonstrated improved efficacy. That means with the cetuximab govitecan, we can handle the primary resistant kind of the thing also, and it was important for that particular population group. Next. Next. Can somebody change the slide? Okay. So safety again, safety profile of the cetuximab is in the subgroup are consistent with the overall study population. No treatment-related death. Discontinuation was 6%. Concomitant GSF use were more in the SG subgroup. Next, please. Next. Okay, this is the conclusion. So, in the subgroup analysis of the phase 3 ASCENT trial, cetuximab govitecan maintained the PFS, OS, and overall response rate benefit as compared to the chemotherapy arm. In both the subgroup, more than 65, less than 65, among patients with the second-line setting with TNBC who have recurred within 12 months of the neoadjuvant chemotherapy or when compared with the individual chemotherapy agent. Safety profile of the SG was consistent with the consistable and manageable across the subgroup. Dose reduction due to treatment-related AEs were more common among those who were more than 65 years of the age. In both the arm, investigators concluded that these data support SG as a new standard of care in the setting of pre-treated metastatic TNBC, including those with early relapse who may be chemotherapy resistant. And the ongoing studies are evaluating SG in earlier setting also. There are NeoStar and the CESSIA trial. Next, please. So this is the last slide, and thank you very much. And for this particular experience, I have not used cetuximab govitecan, so we can't comment. But as we know by the literature and the various podcasts and everything, there are higher incidence of the pulmonary pneumonitis also. And sometimes in the real world scenario, in the cetuximab, there are some deaths also. So over to you, Dr. Devesh, and if there are any question, I will be happy to answer that.
So, thank you, Asim boss, for this discussion. So, as I just want to know what sequence you are using in this triple negative breast cancer in metastatic settings. Patients
So,
comes after the suppose patients recovered from the neoadjuvant, taken surgery and followed by the adjuvant capecitabine, and then relapse after 2 years, gross pleural effusion, lung mets. So, what strategy you will feel that this sequencing is perfect to start, and the patient will get benefited more and more number of months.
So, whatever data says in the TNBC setting, it is very different kind of population, especially if they recur after the first or second line. So, you are asking like patient recurred after the neoadjuvant chemotherapy and adjuvant chemotherapy. So, my first choice is the gemcitabine and carboplatin.
Okay.
Why? Because it is very good to handle drug, and they have a greater response in the triple negative setting in the particular cell lines. And patient is symptomatically very comfortable after 1 or 2 cycles only. And if patient recur after this combination platinum doublet, then I would like to use eribulin. Okay, and if further, if the patient can't afford this govitecan or cestosome govitecan or some other drugs, then I would again re-challenge with the platinum, this paclitaxel if there is no residual peripheral neuropathy, and if it is there, then I would go for the capecitabine or sometimes irinotecan based chemotherapies. And very rare to see the 4th or 5th line, but they are there. Sometimes after the initial aggression, patient end up into some the lucky patient, maybe the disease space is slowed down. So you can re-challenge with the paclitaxel, or sometimes if the patient has a neuropathy, then again you can give the lipodox or liposomal doxorubicin.
Even few of mine patients who have relapsed after 5 to 6 years,
Yes.
I have re-challenged AC, doxorubicin based regimes also. So
Mm.
patient, actually the dose is remained. We have given only 4 cycles. So I just used for initial 4 cycle, then put on the capecitabine. So in my practice, if there is suppose the gap is so higher 5 to 6 years, so in that scenario it's still triple negative. So some patients may get benefited with this re-challenge with this doxorubicin, FAC, FEC, or sometimes CMF, cyclophosphamide, methotrexate, and 5-FU. That works very well in triple negative breast cancer. I have used, but sometimes I think the regimes, I think the 10 apples in our basket to treat the recurrent metastatic TNBC. So we are using one by one or two apple one time, two apple next time, two apple next time. So we can use wisely, and I think depending on the interval between relapse and completion of adjuvant treatment. I think if I am right.
No, that's correct.
Sometimes,
I
sometimes
remember.
if patient relapsed early, if patient relapsed after 3 to 4 years, so can we re-challenge with this carboplatin paclitaxel upfront in comparison to carbogem or platin gemcitabine?
Yeah, you can, but there should be no peripheral neuropathy, because we know patient have a great trouble with the neuropathic complaints. So if there is not, then we can re-challenge, or otherwise you can try the other molecules, gemcitabine, all that. Time is short, but I would like to share my one of my patients. She was a very old lady, treated by some other consultant, end up with me. She had some COPD-like condition, was a lady, and every time, and that she had brain this lung mets also. So there was great difficulty in assessment of like drug is working or not. More in like 2-3 months, she came with the oxygen and stretcher. There, and they used to give the oxygen at the home also, but somehow the drugs work well, and intermittently she used to use the oxygen and support and nebulization, everything. But for 11 months she was on the gemcitabine carboplatin, and very infrequently she used to come sometimes two weeks after, sometimes 3 weeks after, and we used to give, but she lingered on, and we could re-challenge with the some other capecitabine kind of the drug also. So we
But I
can't say
think,
in the every patient, like patient will have a very short span. Sometimes with the comorbidities also patient can survive.
but I think early relapse after adjuvant, I think they are more dangerous.
They are
I
bad. They are
uh,
bad. And
more
most dreaded
delayed
is the
relapse.
brain met.
Uh, Early relapse in my practice, they land up, they gone within 5 to 6 months. Early relapse means after completion of adjuvant treatment within 6 to 12 months, early relapse. So they gone within 6 to 12 months, I think. And if there is longer survival, 5 years, after 5 years, 6 year back, the gap is, so I think they patients are survived more. And 2 to 3 years PFS to 4 years, I think, in that scenario.
But the patients are anecdotal. But still, nowadays, if patient has a high CPS score, you have very good effect with the some immunotherapeutic drugs also. That is the thing.
I think BRCA based treatment can be given olaparib also.
Yes, why not? Why not? But patient generally they are come with the symptoms. So I feel like they should be challenged with the some cytotoxic chemotherapy, and in the maintenance kind of the setting in the metastatic setting, you can use the olaparib kind of the thing.
I think mine experience of breast is very less because I treated the metastatic breast cancer only. Adjuvant settings, I have no lesser number of patients in breast. I think you are treating more and more number of patients at a cancer center.
Yeah, uh, it is there, but Lalit has he is smiling because I guess his son is about to come.
Thank you, Asim boss, for this talk and for accepting my invitation. Thank you. So for next talk, I invite Dr. Lalit, and he is consultant medical oncologist at Manipal Hospital, Jaipur. I think young, energetic, enthusiastic Dr. Lalit, and he will deliver the talk on the efficacy and tolerability of TDX in patient with HER2 low and HER2 ultra low metastatic breast cancer. So over to you, Dr. Lalit.
At the outset, let me thank the organizers, especially Dr. Devesh Boss, for giving us all this opportunity to brush up all our topics. I hope my screen is visible.
Yeah, your screen is visible and is also clear.
Thank you, sir. So, the job cut out for me is to discuss the role of trastuzumab deruxtecan, that is HER2 in the HER2 low setting. So now this is another subgroup which we have identified in CA breast, and this particular approach is kind of revolutionizing the management of these particular patients. So let us see how it works. And the overlay of the talk would be that we would first kind of go through what actually HER2 is classified as, what is the mechanism of action of NHER2, what is the data behind it, how well does it do on the safety front, and what are the current practice guidelines. So if we talk about HER2 low, CA breast is one of the most common disorder worldwide which is affecting females. And unfortunately, the outcomes in the metastatic setting, despite all advancements in the recent past, have remained dismal. Less than 25% of patients will have a 5-year overall survival in metastatic breast carcinoma. Unfortunately, this number is going to be still lower in patients who have HER2 positive disease. So far in the traditional teaching, we have been taught that IHC, when we are going to classify HER2 on the basis of IHC 0 and IHC 1 plus is considered to be HER2 negative, whereas IHC 3 plus is considered to be HER2 positive. The intermediate population, that is the IHC 2 plus, was usually subjected to FISH, and when FISH turned out to be negative, you would consider them to be HER2 negative, and when FISH used to be turning out positive, we would consider them to be HER2 positive. Now, regardless of the status of hormonal receptor in these particular patients, HER2 metastatic breast carcinoma has usually a poor prognosis, and this led to further exploring of avenues wherein outcomes could be improved, and then a particular subset was identified which was classified as HER2 low. Now this would be either IHC 1 plus or patients who had IHC 2 plus but whose FISH was negative. So this is the new population which has been identified as HER2 low. And if we talk about the numbers, this particular population comprises to a large number of metastatic breast carcinoma patients to the tunes of 50 to 60% of our practice. So, volume wise, there is a large number, and treatment option wise, there is a huge vacuum because HER2 directed therapies has so far not been used in this particular setting. So, Destiny Breast 04 was the trial which examined this particular molecule in this particular setting. And on the publishing of the results of this particular successful trial, they were encouraging results, and that led to approval of this particular drug by the FDA, and subsequently NCCN guidelines also endorsed this particular drug in the HER2 low metastatic breast carcinoma setting. So let us see, to start with, what is the mechanism of action of HER2. Enhertu. So Enhertu is basically an antibody drug conjugate. So the antibody part, that is the HER2 directed therapy, provides a targeted delivery of the cytotoxic agent. The uh, cytotoxic part of this particular molecule is a potent topoisomerase 1 inhibitor payload, and it is 10 times more potent than the active metabolite of irinotecan. And it offers a very different cytotoxic drug class than current anti-HER2 cancer agents to help treat tumor resistant to the prior taxanes or microtubule inhibitor therapy. So there is a molecule which is very potent and which has action in second line or third line setting also. And this membrane permeability allows the cytotoxic agent to diffuse across the cellular membrane and kill adjacent cells also, which is known as the bystander effect, regardless of the level of the HER2 expression. Then there is a tumor selective cleavable linker, that is, which is linking the HER2 directed monoclonal antibody with the cytotoxic payload. Now, it is a this particular linker is stable in plasma, and it is selectively cleaved by enzymes which are upregulated in the tumor cells only. So it is released only in the tumor cells. So basically, Enhertu or trastuzumab deruxtecan, it is a antibody drug conjugate. It has target as HER2. The antibody is trastuzumab. The payload is exatecan derivative, and the mechanism of action is by inhibition of the topoisomerase 1. The drug to antibody ratio is 8:1. The tumor selective cleavable linker is there, which helps in release of this particular payload into the cancerous cells or mitotic cells only. And the evidence of the bystander anti-tumor effect definitely is there, which further enhances the efficacy of this particular molecule. Now, once the trastuzumab deruxtecan binds to HER2 found at the malignant cells, it is internalized, and the linker cleavage occurs through the actions of the liposomal enzymes. Now, after it is released through the cleavage, deruxtecan causes targeted DNA damage and apoptosis in the cancer cells. And due to the ability to cross the cell membrane, it is able to affect the nearby cells also, whether they have HER2 expression or not, which is called the bystander effect, which further improves the efficacy of this particular drug. So coming to the data, this particular molecule in this particular setting, that is the HER2 low setting, was introduced on basis of Destiny Breast 04. It was a phase 3 international trial which recruited patients who had metastatic breast carcinoma in the HER2 low setting. HER2 low again is IHC 1 plus or IHC 2 plus with FISH negative. Hormone receptor positive disease was considered endocrine refractory, and these patients received chemotherapy in the metastatic setting or have developed disease recurrence during or within 6 months of completing adjuvant chemotherapy. Patients with hormone receptor positive disease must have received at least one or more lines of endocrine therapy. These patients were randomized in a 2:1 ratio to the observational arm receiving standard of choice chemotherapy or the physician choice chemotherapy, be it capecitabine, eribulin, gemcitabine, paclitaxel, or nab-paclitaxel. The experimental arm that received Enhertu in a dose of 5.4 milligram per kg Q every 3 weekly. The primary endpoint of the study was PFS, and the key secondary endpoints were PFS for all patients and overall survival in hormone receptor positive patients and overall survival in the all patients. Additional secondary endpoints were safety parameters. As far as the demographics of the study go, both the arms seemed pretty well matched, both in the hormone receptor positive scenario and the overall population itself, be it for age, gender, area of presentation, and HER2 1+ or 2+ status. Now, hormone receptor positive and negative population was also equally matched in both the arms. Kindly just pardon me for a few seconds. My laptop is going low on battery. I'm just going to connect my charger. Sorry for the interruption.
Fine. Okay.
So sorry for the interruption. And now the sites of metastasis were brain, lung, and liver, and both almost all sites were equally matched in both the arms. And the prior lines of therapy were also well managed, balanced between the treatment arms. Now, when the efficacy data was published, there was a significant improvement in the Enhertu arm, which showed a median PFS of 10.1 months versus 5.4 months in the chemotherapy arm. And this was supported by an impressive hazard ratio of 0.51. The key secondary endpoint, that is overall survival in hormone receptor positive patients, was also achieved, wherein the median overall survival was 23.9 months in the Enhertu arm vis-a-vis 17.5 months in the chemotherapy arm. And it had an hazard ratio of 0.64. When the PFS and OS was studied in the overall population, that is hormone receptor negative also included, the advantage was still there with a median PFS of 9.9 months in the Enhertu arm versus 5.1 months in the chemotherapy arm. Similarly, overall survival was improved in Enhertu arm with 23.4 months of overall survival versus 16.8 months in the chemotherapy arm. Thankfully, this particular advantage was seen across all predefined subgroups, be it for IHC status of HER2, 1+ or 2+, be it for prior exposure to CDK4/6 inhibitors, be it for prior lines of therapy, that is 1 or 2 or more, be it for age, race, or performance status. The visceral disease at baseline, if it was not there, the advantage was significantly more as compared to if the visceral disease was present at the baseline. More importantly, even the overall response rate was improved. It was not just improved, it was rather tripled. And a decent number of patients, around 3.6%, achieved a complete response also. So, and it was maintained in both hormone receptor positive and negative patient population. The tumor size reduction was also significantly far better in the Enhertu arm. And in the exploratory subgroup analysis, the Enhertu efficacy was consistent even in the hormone receptor negative setting also. The median PFS was 8.5 months versus 2.9 with an impressive hazard ratio of 0.46. Overall survival was 18.2 months versus 8.3 with an hazard ratio of 0.48. Overall response rate was again kind of tripled with 50% versus 16.7% with an CR rate of 2.5%. The median duration of response was also improved, 8.6 months versus 4.9 months. As far as the safety data goes, majority of the patients suffered some sort of adverse events, but the most common severe adverse event was either neutropenia and the Another adverse event of interest was pneumonitis. Around 23% in the Enhertu arm went for dose reductions versus 38% in the chemotherapy arm. Most common treatment related adverse event associated with dose reduction was nausea and fatigue in the Enhertu arm versus in the chemotherapy arm was neutropenia. Dose interruptions were more or less similar in both the arms, 39% versus 42%, and discontinuation was slightly more in the Enhertu arm, 16% versus 8%, almost double. And the most common treatment-related adverse event for discontinuation was ILD or pneumonitis, whereas in the chemotherapy arm, it was peripheral sensory neuropathy. But per protocol, Enhertu was discontinued in the DESTINY-04 in patients who were diagnosed with any symptomatic ILD and pneumonitis, and probably that was the reason why the discontinuation rates were slightly more or kind of doubled. If we are now that over a period of time we are learning how to manage these particular side effects, probably the discontinuation rate would be rather low. Now, ILD is something which we need to watch for while treating patients with Enhertu. There is a defined number, though not very common, but a defined number who might develop ILD on Enhertu. Grade 3 or more ILD pneumonitis occurred in only 2.2% of the patients treated with Enhertu, a rate consistent with the previous metastatic breast cancer trials of the trastuzumab deruxtecan. If we talk about the quality of life parameters were pretty well matched with the chemotherapy arm. Even the nausea and vomiting parameters were slightly better with the Enhertu arm. As far as dosing and administration goes, the recommended dose is 5.4 milligram per kg Q3 weekly once every and it is recommended for the initial infusion over 90 minutes, and if it is well tolerated, the subsequent infusions can be done at 30 minutes as we do in trastuzumab. Dose modifications might be required for grade 3 or 4 adverse events. The first dose reduction is usually to 4.4 milligram per kg, second dose reduction to 3.2 milligram per kg, and despite that, if there are significant adverse events, the treatment might be discontinued. These are recommended dose reductions, and most of us would agree that particular dosing to start with and the reductions would vary from patient to patient and clinical scenario to clinical scenario. Now, dose modification specific to ILD, this is a very busy slide. Do we have time to discuss this in detail, or shall I wrap up? Okay, maybe we can manage ILD and left ventricular ejection fraction as we do in patients who are suffering from similar disorders with either trastuzumab or other chemotherapeutic agents by reducing the doses in grade 1 or 2 adverse events, and if in case the patient suffers from severe adverse events such as grade 3 or 4, probably dose interruption or dose discontinuation might be required. As far as nausea and vomiting goes, it is one of the highly emetogenic drug, and the institutional protocol for highly emetogenic drugs should be followed. Either 3 or 4 drug combinations should be used. I personally prefer combination of nutipetant and palnositron along with at least olanzapine for a week after the infusion of this particular therapy, which usually takes care of the drug-induced nausea and vomiting and is usually not troublesome. As far as ILD goes, grade 1 can be managed with steroids alone. Grade 2 would need discontinuation of the therapy and introduction of ILD and other supportive measures. Reintroduction can be considered in grade 2, but grade 3 and 4, the infusion should be permanently discontinued, and the patient should be managed with steroids along with supportive measures such as O2 and BiPAP support. Uh, So this is what we have already discussed, that we would need drug discontinuation, immunosuppressive therapy in the form of steroids, and supportive therapy in the form of monitoring, hospitalization, oxygen therapy, and potential mechanical ventilation in a very severe scenario. In case of grade 2 or more ILD pneumonitis, NR2 should be permanently discontinued. And to monitor, there should be a regular lung examination, respiratory function test, oxygen saturation by pulse oximetry, and a high resolution CTE is recommended every at least 12 weeks in this particular scenario. Regular assessment is required. Do we have time for a case discussion?
I think already 5 minutes over. 5 minutes over.
Anyways, thank you so much for a patient hearing. To conclude, NHER2 has decent data to support its use in the HER2 low population, with decent improvement in the median PFS, overall survival, and a significant improvement in overall response rate without any major quality of life or adverse event profile. Thank you so much for a patient hearing.
Yeah. Thank you, Lalit. So just want to ask, are you using this drug? Have you tried in low or ultra low setting?
No, sir, I haven't tried in the HER2 low setting, but I've used it in a decent number of patients in the HER2 positive setting. I've used these in two of my patients who were non-breast HER2 expressors also. The drug works wonderfully well. The tolerability profile is also good. So far, I have an experience of around, say, 8 to 9 patients of this particular drug, and it's a wonderful drug, sir.
So you are using the first dose, apparently full dose 5.4, or yeah, first dose
No, sir,
reduction?
I don't go for the recommended 5.4 milligram per kg. I actually did it in the first patient of mine who developed severe neutropenia, and subsequently we had to reduce the dose. Ever since, what I've done is, probably Indian patients and doctors and the public is more used to discounts. So I usually, it depends on case to case basis, but around say 20% lower dose than the recommended is something I found is very well tolerated and is quite efficacious also.
So 4.2 or 3.2, 3.6, I think.
4.4.
4.2.
Yes.
So have you any experience of discontinuing due to grade 3 or 4?
So far, not. Touchwood, I haven't discontinued in any of my patients.
Are you using routine growth factors post TDX?
Yeah, I am. The antiemetic protocol is for the highly hematogenic, and from the very beginning, from the first cycle itself, I give a prophylactic pegfilgrastim.
Okay, fine. Any comments for this drug from your side?
Sir, after few initial hassles, gradually I've come to terms with the side effect profile and all. Efficacy wise, it's a wonderful drug. The first patient I was talking about, in whom we use the recommended doses, for the first 3 to 4 months, we were not able to reintroduce the drug because of the severe adverse event. But when we, after a single dose, when we did a scan after 3 months, the disease was significantly lower. So even a single dose of the medication led to a significant improvement in the subsequent PET-CT.
So do you want to use this after the trastuzumab PER2 or lab TDM1 in third line
At this
or
point,
fourth line?
not TDM1. At this point in time, obviously after trastuzumab and pertuzumab, as the recommendation is for that. But the way the data is evolving, I do have a hunch that gradually probably it's going to turn up as the first line therapy also. Currently, after trastuzumab and pertuzumab.
Okay. So where you fit this TDM1 in the HER2 positive man?
Those who are not able to kind of afford NHER2, yes, TDM1.
Okay. So if there progression after TDX, can we use this TDM1?
I am not aware of any such data, so I would refrain myself from commenting on that.
Okay, okay. Yeah. Thank you. Thank you, Lalit, for this
Yeah,
talk. And
thank
I
you.
think
Thank you.
clarity about this drug. Even you are well versed within this HER2 positive breast cancer. Even I am confident in HER2 positive, but I am trying to try in any low or ultra low positive breast cancer.
Dr.
Any
Manoj
comments
Mahajan
of
sir had raised hand. Probably he wants to
yeah,
give us
yeah.
a
Yes,
Your
comment.
experience, Manoj.
yes. Actually, there is data that TDM won't work in a post NR2 because there is already lower expression, and so TDM has hardly any role after TDXD.
So
So
that
I
you're
think
talking about HER2 low setting, sir, or even HER2 positive setting?
even HER2 positive setting.
Okay, sir.
And one more thing, like I think there is hardly any place for TDM1 except in like affordability you have discussed. The second, I would say, clinical indication would be where the patients have the already pre-existing ILDs or grade 1,
Hmm.
grade 2 ILDs, where NR2 we won't be using. Though TDM has also chances of getting ILD, but much lower as compared to the TDXD. TDXD has around 10% of patient as per the trial data, around 10% patients are getting ILD. TDXD is around 2 to 3%. So I think the pre-existing ILD patients any HER2 low, HER2 positive patients I'll prefer a TDM1 in that particular setting, but that is again very low, like very small subset.
Right.
So I think I heard about Manoj Mahajan who are using the TDX in very large quantity, 50 or 100 patients, I think. The
Nahin,
experience of this TDX in
not
this.
50 patient. I think 12, 13 patients are there.
Okay, okay. No, I have heard about 50 patients, I think.
मैं 50 हो हम उदय उदय उदयपुर से जयपुर तक आते आते बातें बड़ी हो जाती हम छोटे हम छोटे सिटी में बैठे हुए हैं ज्यादा इतने इतने पेशेंट
No,
नहीं
no,
है
no, no. No. Okay, okay. Thank you, Lalit, for this talk, and
Thank you, sir. Thank you
you to
so much.
Wonderful talk,
thank you,
wonderful.
Manoj, for
Thank you, sir.
thank you,
Yes.
Manoj, for clearing all these facts about this TDX in the low as well as HER2 positive breast cancer. So I think without we'll start the second. I invite Dr. Manoj Mahajan. I think he's younger than me and energetic, enthusiastic medical oncologist in Udaipur. And he's on setup as well as in the director in the Pacific Medical College in Oncology Division, Medical Oncology Division. So I invite Dr. Manoj Mahajan for the talk in this recent advances in this metastatic urothelial cancer. So over to you, Manoj.
Yes. First of all, I would like to thank Dr. Divesh for organizing such rarer topics. These are very rarer topics in clinical practice. We hardly use. So once you had given, I had to go through the actual data because these are very, very small subset of patients we see. And that is what, again, I came to know overall survival in these patients are low. Can you just go to the next slide? So as we can see, most of the patients we catch up in early stage. If we look at the overall percentage of patient non-muscle invasive cancer, nearly proportionate diagnosis is around 75%, and 5-year survival rate is 96%. As it advances to localized, now node negative disease, nearly 30% patients, I'll say, are picked up in either node negative or node positive, non-metastatic, I'll say, not M1. So these are 30% of patients, around 30% patients, and 5-year survival rate again drastically reduces from the beyond non-invasive to invasive from 70% to 36%. And in metastatic setting, hardly we diagnose 4% patient at de novo, and less than 5% patients have 5-year survival. So it's extremely poor survival, especially the patient becomes metastatic. So we'll see how the overall evolution of the treatment has evolved over many years. Next slide. So we broadly, as of now, there are two categories: cisplatin eligible, 50% of patients, and cisplatin ineligible. And in eligible patients, the standard of care is gemcitabine cisplatin followed by available maintenance, or dose-dense MVAC followed by available maintenance. And cisplatin ineligible patients, carboplatin-based regimens are followed by available maintenance, and newer drugs like immunotherapy era atezolizumab, pembrolizumab has also marked their presence, especially in the PD-L1 positive patients.
So if we look at the overall long-term survival or median OS in cisplatin eligible patients is more than a year, around 15 months, and in cisplatin ineligible patient it's less than 10 months. So not very promising as where we are led the way in breast cancer, on many blood cancers and lung cancer. This is still hovering around just 1 year. Next slide. So if we look at the overall evolution, for 30 years, cisplatin was the backbone, and another after 2010, carboplatin has been penned as one of the substitute in patients who are cisplatin ineligible. But after the immunotherapy era, from 2017 onwards, there were approvals for atezolizumab and pembrolizumab. Again, they were amended in terms of cisplatin ineligible patients with PDL1 positivity. And then there positive phase 3 trial of atezolizumab, Vigor 130 that we'll see. And in then 2020, we got the approval for avelumab maintenance. So we'll just go through all these important landmark trials which have changed the practice to certain extent. I'll not say to a great extent, but whatever 1 year horizon we have been able to extend up to 2 years with various inclusions of the criteria. So if we see the first landmark trial, IMvigor 210, cohort 1, it's like phase 2 single arm study, only atezolizumab, mainly cisplatin ineligible patients. So what is the cisplatin ineligibility? One is impaired renal function, EGFR more than 30 and less than 60, grade 2 hearing loss, grade 2 peripheral neuropathy, and ECOG PS2. This is classical definition of cisplatin ineligibility. There are certain other parameters where they include NYHA class 3 or impending cardiac function or cardiac dysfunction is also included, not cisplatin eligibility. So primary endpoint in this is simple overall response rates, and secondary endpoints were PFS and duration of response. Next slide. So in this cisplatin ineligible group, if we look at the overall response rates, that came around 24%, and CR rate 8%. So 8 to 10% is persistent in this population of the patients of the immunotherapy, and this responding patients are usually a long-term survival in most of the patients if they are responding. So the median OS increased from 14.8 months to 16.3 months with the atezolizumab, though this is phase 2 trial. So next slide. So if we look at duration of response in patients with the CR, look at the numbers, 119 patients overall, and responding patients in CR are 10, around 9-10%. So median duration of follow-up was slightly more than the intention to treat population. Overall response rates is 24%. And if you look at the overall CR has been achieved in few of the patients after a year also. Like initial responses they have achieved around in 2 to 4 months, and then in few patients the CR have been achieved at the end of 1 year or more than 1 year. Next slide. And this cohort 1 is mainly for efficacy in the elderly patient. If we look at the elderly patients, nearly more than 71% patient had around 20% of responses, less than 75, 16%, more than 65, 15% response. So CR rate is more or less around 20%, we'll say 15 to 20%. Next slide. Another immunotherapy, phase 2 study of pembrolizumab in cisplatin ineligible patients. So in this study, they have included NYHA class 3 CHF as one of the criteria for cisplatin ineligibility. So again, pembrolizumab was given single agent primary endpoint, again overall response rates and overall response rate according to the PDL1 expression. Secondary endpoints were PFS and OS. Next slide. So if you look at the overall response rates, around 30%, CR again around 10%, 9%. Initially it was like earlier study, it was 8%, now it's 9%. So it's hovering around 8 to 10%. And if we look at the CPS score more than 10%, if that criteria is, if we filter out with that criteria, then CR rates has improved from 9% to 20%. And PR rates from 20% to 27%. So slight improvement. So if CPS more than 10 is applied, CR rates are increasing. So probably this subset is the ideal subset where we should go for the immunotherapy. Next slide. So looking at the PFS, in all patients around 2 months, OS in all patients around 11 months. If we apply the PDL1 status, then PFS increases to 18.5 months. So again, from standard 15 months of cisplatin patients to in cisplatin ineligible patients, it has reached to 18.5 months. So definitely there are some promising subsets where we have to think about the immunotherapy in this group if finances is not an issue. Next slide. Then the landmark Javelin Bladder 100 phase 3 maintenance avelumab with best supportive care versus best supportive care in the after platinum based first line chemotherapy in metastatic urothelial carcinomas. So after 4 to 6 cycles of first line, maintenance was designed. It was randomized in 1:1 fashion. Nearly 700 patients, avelumab versus BSC. Primary endpoint, this is the first study where primary endpoint was OS. Next slide. So if we talk about the OS in the overall population, OS was reached around 21.4 months versus 14.3 months with the BSc. So BSc arm is a standard arm where 15 months is hovering, and median OS in the overall population is 21 months. And if we apply the PDL1 filter, then it has not reached at the end of this is 2020 slide. So at the end of it, it has not been reached. Median OS has not been reached. Next slide. So PFS is 3.7 versus 2 months in overall population. In PDL1 population, 5.7 months. So PFS improves. So in PFS and OS definitely improves if we apply the PDL1 as a filter in cisplatin eligible patient as well as cisplatin ineligible patient. But this is a maintenance setting, first line. All these are first line setting in cisplatin ineligible and eligible patients. Next slide. So coming to the second line treatment, again, there is no standard of care prior to platinum, and platinum has been a backbone for even in second line. Again, the poor responses. 2016 onwards, we have few immunotherapies coming up. Apart from the Tecentriq and Keytruda, nivolumab, avelumab, durvalumab has been used in second line in 2017, and then in 2019, enfortumab vedotin has come and it has shown some promising result along with the erdafitinib. So talking about the phase 2 study of atezolizumab in metastatic urothelial cancer after prior platinum therapy. So this is after first line platinum therapy. So number of patients around 300 patients, and primary endpoint was overall response rate. Secondary endpoints were PFS and DOR and ORR. Next slide. So if we look at the overall response rate, it is around 16%. CR rate is around 7%. And if we look at the patients who are responding, they have initial responses within 2 months, and then subsequently few of the patients go into the complete CR. So the crux here, we can see those patients are responding, probably continue to respond after many months as well. And those who are not responding probably won't respond, and we have to discontinue the treatment. Next slide. So based on the PDL1 status, if we look at as the PDL1 positivity improves, overall response rate, CR rate improves across all the subgroups, be it IC2, 3, IC1, 2, 3, all patients. So comparatively, it goes on increasing with the PDL1 status. Next slide. So if we look at cohort 2 OS intent to treat population, the median follow-up OS up to 32.9 months, Tecentriq has demonstrated OS of 7.9 months, 1 year OS of around 37%. So not very impressive as compared to other malignancies, but whatever options we have, these are upcoming options we need to filter out, or we need a refined markers for these patients. Next slide. So coming to the phase 3 trial of the atezolizumab in previously treated metastatic urothelial cancers. So almost large number of patients, more than 900 patients. Primary endpoint in this study was OS, randomized into atezolizumab versus chemotherapy of choice. Patient who has received first or second line of platinum-based therapy. Next slide. So if we look at the OS in the intention to treat population, next. So if 24 months OS rates was 23% versus 13%, at the end of 30 months of OS rates were 18% and 10% respectively. So slightly better. Next. So if we look at the IC2-3 population, the OS is again 33% versus 19% at the end of 24 months, and at the end of 30 months, it's around 29% versus 17%. Next. And at the IC1, 2, 3 subgroup, 22% versus 14%. So I think this is an important parameter we need to have, where the responses, overall survivals are better. Next slide. So the OS by treatment and chemotherapy subgroup. If we look at the Tecentriq versus Taxane, they have fared. Atezolizumab is 8.3 months of OS versus chemotherapy arm of the Taxanes of 7.5 months. And Winflu-9 is 9.2 months versus 8.2 months. So it's slightly pairing. Hazard ratio is again not very impressive, but still, I think in cost constraint or toxicity constraints are there, then we can consider either of the options. Next slide. Next slide. So this is the one largest, probably real world evidence data of phase 3B safety study of the Tecentriq in MUC after failure on prior combination therapy. So if you look at the number of patients, more than 1,000. So this is the largest study of with Tecentriq only. So primary endpoint was safety, secondary endpoint was where OS, PFS, or DCR. Next slide. So safety profile was tolerable, as we have seen in most of the patients do tolerate well Tecentriq. There are hardly any, so there are no new safety concerns in this study as well. Next slide. So if you look at the PFS and OS, so 1 year PFS rates was around 17 months and OS was around 41 months. Median OS of 8.7 months and median PFS of 2.2 months. Next slide. So OS according to age and PD-L1 status, OS was similar across the age group analyzed. So irrespective of the age, OS was similar, and OS is slightly more favorable in IC2-3 population as compared to the IC01, as we have consistently seen in all other studies. Next slide. So again, keynote phase 045 phase 3 study pembrolizumab cisplatin ineligible patient upfront. This is again more than 500 patients randomized into pembrolizumab versus paclitaxel or docetaxel. Primary endpoint was OS. Next slide. So if we look at the OS of around 10 months and PFS of around 3.3 months. So to conclude, this is a difficult to treat subgroup of metastatic cancers, and we have hardly any options apart from the cisplatin and carboplatin for many years. But immunotherapy has changed our overall outlook, including from cisplatin ineligible patients to cisplatin eligible patients in different, and even in maintenance setting, avelumab. So these 3 immunotherapy drug has changed our overall outlook, and we can there are newer studies and upcoming studies are promising in terms of enfortumab vedotin ADC, as we have discussed NR2. Probably this may change overall spectrum of this subset as well. Thank you. Thank you.
So thank you, Manoj. So I think we have discussed this metastatic urothelial cancer. So can we discuss on for 1 minute?
Yes, yes.
So what is your experience to start with? If the patient is cisplatin ineligible, carboplatin ineligible, so apparently you start with this immunotherapy?
Yes, I have used in very few patients. Not that is what I said. We hardly encounter patients in such setting, most of the time, as 75% patients are in the very TIA stage, and by the time they are metastatic, they are either they will have other comorbidities or illnesses. Then that patient also lose hope for continuation of the treatment as well. So
So,
my experience in such subset is around, I guess, 2 or 3 patients I've used, not more than that.
so which drug you use, Pembro or IT?
I have used atezolizumab.
No Pembro?
No, not Pembro in this subgroup. And 3 patients, one of the patients was like survived more than 1.5 years, but the rest like were around 6 months to 1 month, both the 2 patients.
So, do you use this heavy maintenance after the carbogen combination?
No, I haven't used so far, but I would like to use them. I haven't, because as per the data, I would like to go with the data, but I haven't used so far.
Okay. Suppose the patient is not affording for this heavy maintenance. So, in that scenario, what will you do?
Most of the patients are not able to afford, so I think we just give the chemo 4 to 6 cycles chemo. Sometimes gemcitabine maintenance, though there is no data, but either 4 to 6 cycles of chemo and then we stop and then observe.
Okay, fine. Is there any inputs or is there any inputs from your side?
No, I think it was learning for me as well, and we'll try to use. But the only thing is, this subset of patient is rare, and then again, rare patient, you have financial eligibility, the biggest criteria, that becomes again a rare phenomena.
Have you used the DDMVAC regimes in your DM
No,
practice?
I have used it only in my residency, not in my private practice.
So
Only
why?
during residency.
So why we are not comfortable with this regimes, DDMVAC?
It is quite toxic, as even the literature says so, and even the experience says so. But there are newer modified versions where they allow free dosing. There are changed dosagings of platinum, but I haven't used.
So suppose the patient comes, if the creatinine is so high, 4 or 5, and the comes and the metastatic CA bladder creatinine is so high, and on PCN. So, so do you use the carboplatin in that scenario also? So dose comes 40, 50 mg or 60 mg.
No, PCN is like post PCN patient hardly survives for more than 3 months. So
Okay.
I
Suppose the urine output is adequate and suppose creatinine is 3.8, 3.83, and patient is comfortable, but he is on observation for creatinine. So do you use this carboplatin in that scenario, carbo-gem combination?
No, even carbo, I think carbo has less than 30 ml per minute is again relative contraindication, I'll say.
But
Ultimately,
I have used the carboplatin AUC. I think I'm using the 21-day schedule. So dose comes between 150 to 200 milligrams every 21 days. So I
okay.
use on the day 8, I have used on the first day, day 1, only gemcitabine, and day 8, the carbo-gem. So the dose of carboplatin comes to, so I am using every 3 week schedule the carboplatin. Creatinine is similar on 3.83, 3.6, 3. So creatinine is so in this range, and the response is I have used in 2 or 3 patients in my patient recently. So I am using the
Okay.
carboplatin only on the day 8 schedule because the 2 weeks gap comes after the day 1 schedule. So day 1 only
Yes.
gemcitabine single and day 8 carbo gem. And the carbo dose comes almost 200 or 225 milligrams. So I am
Okay.
using 3 weekly schedule. So 3 or 4 patient I have tried this pattern in CKD patient.
But are they like basically how long the response is going? That is, duration of the response is also important. Even if they respond, because the once, like, I think the patients are on PCN, not on a CKD per se, but PCN obstructive phenomena, then they will have certain, like, tumor will grow and again obstruction will ensue, and then it will be difficult for us. So most of the time I go for the best supportive care rather than pulling on.
So do you still use the single agent gemcitabine in that in these patient?
Sir, sorry for intervening, sir. Sir, we are running short of time, sir.
Yeah, okay, fine. We will conclude within 1 minute.
Yes. Rarely I use single agent gemcitabine.
So thank you, Manoj, for this
Yes.
talk, and thank you for your inputs in this rare
Thank you.
and we are treating this metastatic urothelial cancer.
Yes.
So for this next session, that is the Merck sponsored session. I invite Dr. Ananya Parikh, and she is consultant medical oncologist and Renova Cancer Center, Jaipur. And the talk is the maintain to extend right approach to maximize overall survival in metastatic urothelial cancer. So over to you, Dr. Ananya.
Thank you, sir. Good evening once again. Thank you for this opportunity and thanks to Merck. I'll just share my screen. So I think most of the things Manoj sir has already covered. Just 1 second. So sir has already discussed most of the things, initial things. So I'll just try to finish it early. So as we all know that platinum containing cisplatin gemcitabine has a good initial response, but the response is not that durable, and within 6 to 8 months of the time we have to start the patient on some sort of second line therapy. So is there any role of IO upfront? So I think we have already discussed these are the negative trials, initial negative trials. Now there is a role definitely. So initially Danube, Keynote 361, IMvigor 130 with they compared Durva, Atezo and Pembro with CT, and there was no significant improvement in the overall survival. Now is there any role of CT plus IO? So these were the initial negative studies, that is IMvigor 130, which compared atezolizumab plus platinum gemcitabine versus placebo plus platinum gemcitabine. There was no significant difference in the median OS. And then there is Keynote 361, which compared Pembro plus chemotherapy versus CT, and there was no significant improvement in the overall survival seen. So now after 2017, what are the newer upcoming therapies or the therapies which have already established? One is enfortumab vedotin, which has come in 2019. In 2020, Javelin Bladder 100 gave us avelumab first line maintenance. And now there is Checkmate 901, which gave Gemcis plus nivolumab followed by nivolumab maintenance and Pembro plus EV in 2023. So we're going to discuss that maintenance IO in patients who do not progress post PBC, upfront IO plus cisplatin in eligible patients, and enfortumab vedotin in all patients. Platinum eligibility criteria still remains an important criteria to strategize the treatment maintenance. So this is the usual line of treatment which most of the physician follows if the patient is affordable. That first line of chemotherapy we give. If the patient is having CR/PR or stable disease, we stop the chemotherapy and start the patient on switch IO maintenance, that is avelumab, till disease progression or unacceptable toxicity. Then we initiate the second line therapy. So why we give chemotherapy before avelumab? As it decreases the tumor burden to achieve the disease control and increase the immunogenicity of the tumor microenvironment. And after this, immunotherapy is more effective in the patients with the reduced tumor burden. So we are all aware with the Javelin Bladder 100 study. Sir has already covered this. So in this, the induction chemotherapy was given 4 to 6 cycles of platinum agent with gemcitabine, followed by the radiological assessment and a gap of 4 to 10 weeks. The patients with CR/PR or stable disease received either avelumab 10 mg per kg versus best supportive care alone. So the primary endpoint was overall survival, and primary analysis population were all the randomized patients, plus there was subgroup in which PDL1 was positive, and it was 51% of the patients had PDL1 positivity. The secondary endpoints were PFS, OR, time to response, response duration, disease control, safety and tolerability, and patient-related outcomes. So maintenance avelumab has definitely changed the first line treatment, with the median or overall survival just being doubled of 15 months with chemotherapy alone versus 23.8 months with avelumab maintenance. So median OS measured, if we measured the median OS from the start of the chemotherapy, then also there's definitive improvement. It is toward 9.2 months improvement in the median OS and 23% reduction in the risk of death. So this is the best supportive care arm. So most of the patients, 73% of the patients who were on best supportive care received subsequent treatment with PD-1 or PD-L1 inhibitor. So even PFS was doubled with avelumab as compared to no maintenance therapy, that is of 2.1 months with best supportive care versus avelumab plus best supportive care of 5.5 months. So these are some of the side effects which were seen with avelumab, the most common being the pruritus, followed by hypothyroidism, followed by diarrhea and infusion-related reactions. So this we have already discussed. Now, this is the Javelin Bladder 100 study contained subsequent number of Asian subgroup. That is 147 out of 700 patients were Asian. So similar sort of median OS and PFS benefit was seen in the Asian patients as well. So 61% of the Asian patients were alive after 2 years, and more than 10 months of median OS benefit was seen over non-avelumab maintenance patient, and 3 times higher PFS was seen as compared to the non-avelumab maintenance patients. So how long should we continue the avelumab maintenance? So the median duration of treatments, median PFS of 26.7 months was seen in the patients who were on Bavencio maintenance for more than 12 months, and median OS has still not reached. So median duration of the treatment was 25.3 weeks, and 20% of the patients who were exposed to avelumab were given treatment, has taken treatment for more than equal to 24 months. Patients were exposed, 28% patients were given treatment for more than 12 months, and 47% of the patients were given treatment for more than 6 months. So these are some real world studies. The one which is being done in US is a Patriot 2 study. It is an ongoing retrospective study. The largest study is being done in France, which is Evenance study. It is also an ongoing real world MB-spective study. Then we have the study READY, which is being done in the Italy. So as we can see that all these studies, Evenance, READY and Patriot 2 have replicated the similar sort of median PFS benefit and median OS benefit, or sometimes even better only in READY and Patriot 2 study. So these are the ASCO GU 2024 update of Evenance study. It is one of the largest real world study which included 595 patients. It is currently ongoing and it is evaluating the effectiveness and safety of avelumab first line maintenance, and the updated data in addition to the analysis by subsequent second line treatment is also being reported in the study. So the unprecedented median OS of 40.8 months achieved in this Evenance study only, and this is the largest median OS benefit reported till now. So what is the continuation maintenance? Of course, we have discussed this, that we should continue the avelumab maintenance, and after disease progression, we should start the second line therapy. So this is the newer study, which is Checkmate 901, because of which the Nivo plus Gemcis followed by Nivo maintenance has got the approval in the category 1 indication in NCCN. So this is a positive trial. Median OS was, there was a significant benefit, but the benefit was kind of similar with the IMvigor and Keynote study, that is just of 2.8 months. So this is the study design. Key inclusion criteria was age more than equal to 18 years, previously untreated, unresectable metastatic urothelial cancer involving the pelvis, ureter, bladder. The patients were included were only cisplatin eligible patients. So patients were divided between Nivo plus Gem plus Cis versus Gem plus Cis, followed by nivolumab maintenance therapy. The maintenance was given at the dose of 480 mg every 4 weekly. Primary endpoints were OS, PFS. Secondary endpoints were OS and PFS by PDL1 more than equal to 1%. So efficacy outcome. So there was median PFS benefit of only 9 days and median OS benefit of only 2.8 months, which was kind of similar to the previous negative studies. So the data is more positive with the Javelin Bladder 100 study, in which the avelumab maintenance was given as compared to this regimen, gemcitabine cis plus nivolumab followed by nivo maintenance. So this data also shows that the maximum benefit of median OS of 31 months is seen with the Javelin Bladder 100 study only. So this is another study in which we can compare the first line treatment of avelumab maintenance with IO plus, that is pembrolizumab plus ADC antibody drug conjugate, that is enfortumab vedotin. So the study is a positive trial. It met the PFS and OS endpoints. We'll just look at the study. So the patient, this is EV302 and Keynote A39 study. The patient population were previously untreated. So both the populations were included, that is cisplatin eligible as well as cisplatin ineligible. PDL1 inhibitor naive patients were taken. eGFR was more than equal to 30 ml per minute and performance status of less than or equal to 2. So patients were divided between EV plus pembrolizumab versus chemotherapy. There were dual primary endpoints, that is PFS and OS, and selected secondary endpoint, that is overall response rate and safety. So OS, if we can see here, there's a clear separation of the curve, and there was the OS benefit of median survival follow-up 17.2 months and 31.5 months of median OS versus 16.1 months. So definitely this was a positive study. So only 29% of the patients received a subsequent line after EV plus pembrolizumab, mainly with platinum-based chemotherapy, and there are no evidences that platinum work is safe after EV plus P. So because why this happened? Because there were subsequent significant side effects, especially the more grade 3 events were quite more in this study. 15% of the patients had more than equal to grade 3 skin reactions, followed by 6.8% grade 3 peripheral neuropathy. So these followed by hyperglycemia, grade 3 hyperglycemia in 6% of the patients. And this rate, any grade, was quite higher. That is 66% of the skin reactions, followed by 63% patients had peripheral neuropathy, and 13% of the patients had hyperglycemia. So these were the quite significant events. EV even gave the box warning of serious skin reactions, which can include severe and fatal cutaneous adverse reactions, including Stevens-Johnson syndrome and toxic epidermal necrolysis. So we should closely monitor the patient for the skin reaction. So as we have discussed this, so peripheral neuropathy and ocular disorder monitoring is required with EV. Any grade alopecia was quite high, 1 in every 3 patients. So India is already a diabetic population. Hyperglycemia monitoring is more crucial with this. So if we compare this with avelumab maintenance, the median PFS is kind of similar, 13.6 in the real world data versus 12.5 months. Grade 3 reaction adverse events rate is 19.5% versus 55.9%. There is a very less discontinuation rate with avelumab maintenance as compared to EV plus pembro. So NCCN guidelines have clearly mentioned that all these are the category 1 indications in cisplatin eligible versus cisplatin ineligible. So in an ineligible, we cannot use avelumab, but definitely in cisplatin eligible, we can use pembro plus enfortumab. And so this is the summary in which we have seen that real world data of higher as compared to all the other studies. So just to summarize, that platinum-based combination chemotherapy is recommended first-line treatment for all the platinum-eligible patients. Unprecedented median OS of 40.8 months is reported with the real-world data. Sequencing of available agents will be the key to managing the metastatic urothelial carcinoma, and avelumab maintenance treatment is category 1 or 1A recommended by NCCN or ESMO guidelines. And real-world studies are consistent with the efficacy and safety, which is seen in the Javelin Bladder 100 study. Thank you, sir.
So thank you, Ananya. So I think we have discussed the various points in the with this Dr.
Yes, sir,
Mohan.
definitely.
So your experience and your inputs for AV maintenance, avelumab maintenance.
Sir, I have not used any maintenance therapy. There was one patient, which was of Ankit, sir, but then the patient progressed after, I think he has taken quite a lot of cycles. I don't remember, but I have never used avelumab maintenance till now.
So first thing, this second thing, do you want to use this CIS-GEM or NIVO?
Sir,
Do
the
you
voice.
want to use after this data in NCCN category 1 is category 1 recommendations?
Sir, with this data, I would definitely like to use platinum agents, specifically if patient is cisplatin eligible, then cis plus gem followed by avelumab maintenance. That is the highest median OS was reported.
So you are using this immunotherapeutic drugs. So any side effects with this immunotherapeutic drugs more common you are encountering in day-to-day practice? And any rare side
Most
effects?
of the time I'm using pembrolizumab, not in this setting, in the different setting, and that too it is quite well tolerable. Matlab, not any significant side effect I have not seen till now.
Okay. So any rare side effect of immunotherapy?
So pneumonitis I have seen when I was doing my residency, and colitis I have seen. So these two are the side effects which I have seen, and pneumonitis of grade 3, sir.
Any thyroid dysfunction? Any endocrine related disturbance?
Sir, not like I have not seen, but yes, they are quite common, definitely.
Yes. I still I have seen the even myositis, even the
Okay.
fever, even the arthritis, even skin changes, even endocrine disturbance. I have seen almost all side effect related
Of
to this.
immunotherapy, definitely.
Yeah. So thank you, Ananya, for
Thank
this
you,
talk.
sir. Thank you so
And
much.
thank you. So next, for next talk, I invite Dr. Ankit Nehra, who is consultant medical oncologist at HCG Hospital, Jaipur. And I think very rare topic, and we are very rarely treat this non-clear cell metastatic RCC. So, Dr. Ankit. So I think we are, I think sarcomatoid is variant in also in non-clear metastatic RCC, I think. So I have seen this one or two cases of sarcomatoid variant of RCC. So I think we will teach by you. So what do you, Dr. Ankit, for this talk?
Thank you so much, sir, for giving me this opportunity. I know this is a very rare topic which we are going to discuss. So my first apology, I'll start with that, that there are no graphical presentations
Okay,
because
okay, fine, fine.
all of the study of phase 3 or phase 2, that was the post analytic Hawk analysis with the subset of the patients. But still, we'll go ahead with this. I'll just share my slides. And the last topic was what you were talking about. I have seen most of the patients do get hypothyroidism or initially hyper, but ultimately go into the hypothyroidism. If my slides are visible, then I'll start, sir.
Yes, sir, your slides are visible.
So,
Thank you, sir. So I'll be just talking about the management of non-clear cell metastatic RCC. So although there are many advancement in the setting of clear cell RCC, but still non-clear cell RCC has been challenging one because of the rare presentation, because of the rare incidence as well. And this is $1 million slide. The 80% of the patient are clear cell RCC, and then comes the papillary RCC type 1, which is usually 10%, which is due to the c-MET overexpression. Then the clear cell RCC type 2, which is again 10%, that is due to the fumarase gene mutation. Then chromophobe type, and then collecting duct cell, which is usually we can say it is a mix of RCC and a urothelial malignancy. Then there is a hereditary leiomyomatosis RCC type, which is again due to the FH gene mutation. So most common subtypes are papillary, chromophobe, collecting duct, translocation carcinomas, and unclassified RCC. As sir was talking about the sarcomatoid RCC, so nowadays sarcomatoid RCC is not considered as a distinct subtype. Because it is present in all of the histology. So what is the prominent histology apart from the sarcomatoid? We treat the patient accordingly. And this is the MSKCC and IMDC criteria for poor prognostic or favorable prognostic or intermediate prognostic criteria. So coming to the papillary renal cell carcinoma, so there are few treatment options. Either the patient opts for the IO combination or IO-TKI combination or only TKI therapy. So this is the first nivolumab with the ipilimumab, which was a phase 3B for a prospective study, Checkmate 920. Only 52 patients was in that subgroup was non-clear cell RCC, and in those 52 patients, only 18 patients were there who were having a papillary histology, and the objective response rate was almost around 28%. Lenvatinib plus pembrolizumab, which was the again promising combination. It was a single arm study noted in the Keynote B6 1 trial. 158 patients with the systemic therapy naive patients who are having an advanced non-clear cell RCC of varying histology as well. And in those subgroup, 93 patients were having a papillary histology, and that showed a ORR of 54% with the complete response rate of 9% and the 1 year progression-free survival for 67%, which again led to the NCCN Category 1 guidelines for the non-clear cell RCC patients. Again, this combination very well known in the clear cell RCC patients, but in non-clear cell nivolumab with the cabozantinib, single arm phase 2 trial was there, who evaluated 47 patients. It was published in 2017 and after that in 2022 as well. And there was in that 47 patients, only 32%, 32 patients was there who were having a papillary RCC. Objective responses were seen in 47% of the patient. And additionally, if we talk about the objective responses in the FH deficient, which is papillary type 2, and it was seen in all of the 5 patients and showed a very good response. And those the patients who are not affordable for the IO-TKI combination targeted therapy, if we talk about. So there was a randomized trial, open label phase 2, PAPMET, which conducted a 152 patients of papillary RCC. Majority of the patient was treatment naive, and either with the risk stratification, either intermediate or poorest. Either type 1 or type 2 histology, both were there. Type 1 was slightly lower, it is only 18%, and type 2, which was usually due to the FAM mutation, FH mutation, which was 54% of the patients, was assigned for either to receive a cabozantinib, sunitinib, crizotinib, or savolitinib. So out of that, cabozantinib proved to have a improved PFS, which was 9 versus 6 months. Hazard ratio was 0.6 with the p-value being significant. Objective response rate was 23 versus only 4%, and even 5% of the patient had a complete response with the cabozantinib as well. Coming to the sunitinib, there was 2 ASPEN or ESPN trials. So ASPEN trial was 108 patients previously not treated, was randomized between sunitinib or erlotinib, everolimus. 2/3 of the patient had in those patients, 2/3 of the patient had a papillary RCC. Other was either chromophobe type or translocation type, unclassified type, or sarcomatoid variants or histology or clear cell type. Typically talking about the papillary RCC. So the sunitinib improved the PFS in the whole population, which was 8.3 versus 5.6 in the everolimus arm, with the 2-year PFS rates of 23% versus only 9%. Although the overall survival benefit was not seen. Another trial, again phase 2 trial, ESPN trial, 73 patients of non-clear cell RCC, again randomly assigned between sunitinib or everolimus, and it was a crossover trial, so we were not expecting any overall survival benefit because it was a crossover. But the objective responses were seen in 9% of the patient who were treated with sunitinib initially, apart from only 3% in the everolimus arm. So either a cabozantinib or sunitinib is way to go if the patient is not affordable in the papillary subtype, or if the patient is affordable, so probably pembrolizumab with the lenvatinib, or nivolumab with the cabozantinib is a way to go. So talking about the mTOR pathway inhibitors, we have already talked about it, but the RAPTOR trial, those the patient who are actually having a mutation positive, either this. So the Raptor trial was 88 patients who were treatment naive, papillary RCC, treated with the everolimus. It was a phase 2 trial. The stable disease was found to have in 65% of the patient, with the median PFS of 4 and median OS of 21 months. And ARCC trial of again advanced RCC, where there was a subset of the patient in papillary subgroup as well, where they were assigned between temsirolimus or interferon alpha. It was a previous study, and almost more than 600 of the patient was there in that phase 3 trial. So temsirolimus improved the overall survival, which was 12 months versus only 4 months. And among that subset, only 20% of the patients were papillary variant. So it was really difficult to find out whether the mTOR inhibitors is a way to go in this population of the patients. And experimental MET inhibitors, crizotinib phase 2 create trial, only 23 patient, did not give any kind of significant response. Only 2 patients achieved out of 23 a partial response. With those 2 patients respectively to achieved a 2-year or 3-year of survival. Then chromophore renal cell carcinoma, second subtype. So this chromophore type is quite responsive for the mTOR inhibitors. So initial treatment with the mTOR inhibitor pathway or a VEGF inhibitor is a way to go. And everolimus, there has been as we have already discussed, the ASPEN trial, if you talk about, in that 108 patients, 16%, which is 15% of the patient, was having a chromophobe histology, and overall responses relative to sunitinib, where sunitinib responses was higher in the papillary subgroup of the patients, papillary RCC. The overall response rate was 33% versus only 10%. So in these subset of the patients, mTOR pathway is the way to go, because it is the same pathway which actually because there is a mutation in the chromosome 17, which leads to the loss of folliculin, and Bird-Hart-Dube syndrome is very known etiology for this subgroup of the patient chromophobe type. And the median PFS was 12 versus only 6 months with the sunitinib. And coming to the very rare subtypes, collecting duct and the renal medullary carcinoma. So collecting duct carcinomas are a transition between the RCC and the urothelial carcinoma. So cytotoxic therapies are the initial therapy rather than going with the VEGFR. And the upcoming trials which are coming with the immunotherapies, there might be a chances that as we are talking in our previous discussion, starting with the chemo combination, then maintenance with the avelumab or only immunotherapy, which can be possible if it is proven with the data. But at this point of time, only cytotoxic chemotherapy is a proven treatment with the platinum-based doublet, either cisplatin gemcitabine or gemcarbo or paclitaxel carbo. Limited data is there with the immunotherapy, which are again investigational, which are coming in very short period of time. Collecting the RCC, again, very aggressive tumor. Unlike other non-RCC subtypes, collecting the RCC responds to the cytotoxic doublet very well. There is an open label trial of 23 patients, again a phase 2 trial of collecting the RCC, where gemcitabine and cisplatin was given. Objective response was seen in 26% of the patient, with the overall survival of the 11 months. And medullary RCC still is a very aggressive tumor, which is usually found in those patients who are having a sickle cell trait disease. We do not usually see because it is more common in African population. So, till date, there is a very less amount of data. So it is limited to observational studies as well. There are no phase one or beyond studies at that time. So at this point of time, platinum-based doublet chemotherapy is standard of choice. And there was a one case series of 52 patients with the medullary RCC. And 85% patient was treated with the platinum doublet. In those 30% patient did a showed a very good response rate, and the 2-year overall survival was 13%. Other combination can be immunomodulatory drug like bortezomib, sunitinib, but do not have any exact data, and it is a very limited activity as well. So at this point of time in renal medullary carcinoma, chemotherapy or chemo with the IO, which is coming up, is a standard of care. So, with summarizing my slides, so either the preferred option in the non-clear cell histology, either the cabozantinib or cabozantinib with the nivolumab or lenvatinib. This is for the papillary RCC because 70% of the patients are clear cell, 20% of the patients are papillary, then remaining patients, if they are chromophobe type, then we should consider the everolimus. And other than that, it is chemotherapy. With that, thank you so much. Thank you, sir. I wanted to very brief about it.
Thank you, Ankit, for this. I think the very rare topic, and I think very rare we treat this subtype because we are seeing maximum number of clear cell type of RCC in our routine OPD practice, and definitely we are using the IO plus the cabozantinib, various regimes, pembro with TKIs and nivo plus TKIs. So we are using various regimes in this IO combination in this clear cell. But non-clear cell, I think my experience is very less. I think I have still not seen any case of non-clear subtypes, even in 15 years of my journey. So thank you, Ankit, for this very rare topic and for this my invitation for attending this. And
Thank you, sir.
further
Thank you
moving
so
ahead,
much.
so I invite Dr. Anu Rajpurohit for panel discussion. And he working in the Medipulse Hospital as a consultant medical oncologist. And I invite Dr. Anu. So over to you, Dr. Anu, for this panel discussion. Yeah, your voice is not audible, I think, unmute. So for panel, I invite Dr. Abhishek Sharma. He is consultant medical oncologist at Goel Hospital, Jodhpur. And Dr. Mukesh Chaudhary, Cancer Hospital, Jaipur. Dr. Abhishek Charan from the HCG Cancer Center, Jaipur. Dr. Neha Rawat from the Durlabji Medical Hospital, Santoba Durlabji Hospital, Jaipur. And Dr. Vinod from RHL Renova Cancer Center. I think, Anu, you unmute. Okay, fine. Arham, please see the issue.
Ma'am, you want to share us slides? You want us to share?
I think Dr. Abhishek, you are there.
Yes, sir. Yes, sir.
And Dr. Vinod.
Ma'am, should I share the slides? Hello, ma'am. Sir, ma'am is unable to
So
join, so she's rejoining from her phone.
can you contact? So, Dr. Abhishek and Dr. Vinod, can we
So
discuss?
just wait for 1
Can we
minute.
discuss? Yeah.
Sure, sir. Sure, sir.
So, how are you? So, Dr.
I'm good,
Abhishek,
sir.
how are
How are
you?
you doing? I'm good, sir. How are
Fine,
you
fine,
doing?
fine. So, yeah,
Thank
fine.
you, sir, for
So,
having me.
yeah. So going on this CA ovary, I think Dr. Anu Raspurohit is connecting. So, I think what is your choice? What you start with this in ovarian cancer? Are you using this?
Sir, upfront or in relapse setting? Hello? Hello?
Technical team, can you please look? Dr. Anu ma'am is not unable to.
Hello? Hello? Am I audible, sir?
Yes, you are audible.
Yes, sir, you're audible.
Yes, sir. Sir, you asked a question, sir? Devesh, sir.
Am I audible now?
Yes, ma'am, you're
Dr. Anu, you
audible.
are audible.
Okay. Sorry for the delay.
Should I share
Not
the
an issue.
slides, ma'am?
Yes, now you have to share because my laptop
Yeah,
isn't
sure, no
allowing
problem.
my
I will
audio.
share.
Okay, sure. Okay.
So I think Dr. Anu, we
Okay,
will
so-
conclude within 15 minutes. I
Sure.
think
I'll
dinner
keep
time
it
is over.
fast and brief. And thank you, Devesh sir, for
Yeah.
this webinar and giving me this opportunity to discuss this very important topic. So I
So
welcome
I am
all the
also
panelists.
I am also part of this the panel discussion. I think Dr. Abhishek and Dr. Vinod is there and myself,
Okay.
all my.
Okay,
Dr.
sir.
Mukesh will join in 2 minutes.
Okay, and Dr. Neha?
She is unable to join
Okay, no
due to
worries.
some reasons. Yeah. Okay.
Okay. So we'll start. So our topic is management of recurrent ovarian cancer. Next. Next. Okay, so let's talk about the India. It's the 8th most common malignancy in India, we all know. And if we talk about especially for the female, it is 3rd most common malignancy after breast and cervix. Annually, we reported cases are around 45,000. And what are the death figure? It is 32,000. Next. Can you move to next slide? Yeah, start. So let's start the first case. So patient is 60 years old female, no significant comorbidity. In November 2020, presented with abdominal distension with raised CA125, which is 1056. On workup, pelvic ultrasound is showing ovarian mass on both these sides. In MRI, there was tumor deposit of the ovaries. around 6.7 into 4 into 4.57. Similarly, on left side, it is around 5.8 centimeter with peritoneal carcinomatosis with ascites. CT showing the ascites, peritoneal carcinomatosis, liver surface deposit, and the lymph nodes. Later, the biopsy was done and it showed WT1 positive P53 mutant ovarian cancer. Next. Yeah. So if we talk about the treatment part, so patient was started on neoadjuvant, which is carboplatin paclitaxel. Patient had good partial response, for which she underwent interval cytoreduction, and then she was started on adjuvant chemotherapy, similarly like the carboplatin and the paclitaxel, and later was put on observation. So in this case, we start with Dr. Abhishek first. What do you think in workup part as well as in the neoadjuvant part? What is missing? What could have been done the extra? So let's talk about the first neoadjuvant. Patient has advanced disease with ascites. Do you follow the same, the paclicarboplatin, or do you want to add something in this?
Ma'am, I prefer Paclicarbo. I keep bevacizumab at the relapse setting, not upfront, ma'am.
Okay, okay, okay. And what about the other panelists? Do you agree with Dr. Abhishek or you have different opinion?
Dr. Vinod is there. Dr. Vinod is there.
So I think bevacizumab remain an option for PFS benefit, and other things are like we have to do HRD, then BRCA, chromatic BRCA. These
Definitely.
are options in 2022.
Yes. So are we practicing all like HRD or at least BRCA in the baseline upfront only?
So germline BRCA for every ovary, prostate, pancreas, and breast patient.
Great. Okay. So let's coming back to this patient. So patient was not given bevacizumab, neither she was given any maintenance therapy here. So she was disease free till June 2022. So in relapse, there was 5 centimeter pelvic mass with 2 centimeter subcapsular deposit. Next slide. Okay, so very important topic, how to decide for the secondary cytoreductive surgery. We can start with Dr. Divesh sir also.
I think still I have not seen in my practice for secondary cytoreductive surgery in
Okay.
throughout. So I think can we assess with this AGO OVR score?
Definitely, yes, sir. Yes, sir. So what is the opinion of our other panelists? Do you follow this score or you use some other scoring like I model, or you totally leave this on surgeon? What is your call, or you discuss in the tumor board?
So not dependent on surgery at all. So we will go for with AGO over score. I'm not sure about the I model score, but
Yes.
if the criteria of AGO over score are fulfilled, then I can take surgeon opinion for the resection.
Great. Okay. So Dr. Abhishek, do you also agree with this?
Yes, ma'am. Yes, ma'am. I feel the same. If platinum sensitive disease, less burden disease, no ascites, and good DFI period.
Yes.
Definitely, if patient is meeting AGO criteria, then we
Yeah.
should consider
Yes.
the second
We-
cytoreductive.
Okay, correctly mentioned all the points by the Dr. Abhishek that these points should be fulfilled, and then later we can plan for the secondary cytoreductive surgery. Yeah, next. Next slide, please. So this is the NEGM paper which shows the randomized trial of cytoreductive surgery for the relapse ovarian cancer. Next. Okay. So on your left side, which is highlighted, these are the point of AGO score. On the right side, they are showing the clear benefit of doing secondary cytoreductive surgery over no surgery. This is the continuation of the palliative chemotherapy. Next. Next, please. Again, this graph is showing the similar result. The superiority of having the RO resection in the secondary setting over the no surgery. So next. Yeah, you can move next. Next. So these all the studies and papers all are in support of doing the secondary cytoreductive surgery. Next. Yeah, next. Okay, so this we can follow. Actually, we should look for the disease-free interval. Then we should focus on the site of the disease, whether it is single site, multiple site, and then importantly, carcinomatosis is there or not. Because if carcinomatosis is present, then there's no point of doing secondary cytoreductive surgery if the disease-free interval is shorter. Next. Okay, so again, the NCCN is showing the similar points. I need to discuss one case with you here. That was my one patient, she ovary high-grade serous. So initially, a neoadjuvant surgery adjuvant was given. She was not given bevacizumab or a PARP inhibitor because it happened 3-4 years back. Then she presented with liver parenchymal lesions only without any retroperitoneal lymph nodes. So we did hepatectomy and then we put her on the PARP inhibitor, which is rucaparib, and she's doing good, and it has been 2 years. So my experience had only with one patient, and it is good till date. Okay, thank you. Next slide. Okay, so coming back to the case, so from July 2022 to November 22, again, she was offered platinum because she was platinum sensitive. Again, very good partial response. Now let's discuss the role of PARP inhibitor here because in the baseline, we didn't do the HRD or BRCA test. So let's discuss with Dr. Vinod.
Yeah, so this is a relapse setting. So I think current approvals are only for mutated BRCA and germline. So
Okay.
I don't think for PARP are at present approved for wild type or HRD positive but BRCA negative in a relapse setting.
So if BRCA negative and still the disease is HRD positive, do you consider giving PARP inhibitors, sir?
So it's not approved, so I won't give.
Okay, but the benefit was shown in the trials. Dr. Abhishek, Dr. Devesh, sir, what do you think? What is your take on this point?
Ma'am, I agree with sir because there is,
Yeah.
although some clinician do give, but I don't
Yes.
prefer giving unless and until it is positive. Though
Okay.
some are giving rucaparib off label, but I think we
Yes.
should. I won't give, ma'am, personally.
Okay. You won't give her.
So we can't. So just my query. So we can't try in this HRD positive.
I think we can give,
HRD we can
but
give, sir.
we
HRD.
can.
So regulatory approval
So
is not there, sir. It is only for mutated BRCA only.
Yes.
Off label one can
not
give,
for
but
HRD positive.
not for HRD positive. So all the three drugs are only approved for mutated.
Yes.
Okay.
But if clinician pays and patient also agrees, and then we can offer.
Sir, HRD we can give off label consent if we can.
So I'm not sure how much it will benefit, how much PFS it would benefit. If there is no regulatory approval, then it is always there is a concern because we know that there should have been approval if there had been quite a good benefit. So there would be other reasons we might not be aware of that because we can't read each and every like drug or every situation in every cancer. So in this situation, I will go with regulatory approval because these are associated with life-threatening side effects of AML and other things. So outside of regulatory approval, you can put down, you can take a consent from the patient. Otherwise, it can be problem. People do many things off-label, but it's always better to put yourself on safer side.
Yeah, we agree with this point that we should take care of medical legal things also. Yeah, next slide, please. Can we move to next slide, please? Yeah, next. So one more point, because we are discussing the secondary cytoreductive surgery in the era of PARP inhibitor. Suppose the patient is BRCA positive and there is a recurrent disease which is amenable to surgery, but because the desktop trial was done when this thing was not there, the PARP inhibitors were not used. So what do you think in the era of PARP inhibitor, doing secondary cytoreductive surgery is useful or not?
I think very few of patients can be rechallenged if there is very limited disease. and good performance status, we can challenge with this secondary cytoreductive surgery. Otherwise, I think there is no more benefit for this secondary cytoreductive surgery if disease burden is so high, metastatic. I think very few or very limited number of patients we can offer this secondary cytoreductive surgery.
Yes, I agree, sir. Definitely, we need to see the patient's profile and the other points which we discussed previously. Next slide, please. Next slide.
I think please move early. Okay, fine.
Yeah, so these are the ESMO ECF consensus for the maintenance therapy. So in this, they've mentioned that the patient with BRCA wild type or unknown tumor eligible for the platinum or no prior PARP inhibitor, no prior bevacizumab, then maintenance therapy is recommended with PARP inhibitor, whether after CRPR. Next, please. Okay, so February 2023, after giving the Paclitaxel second line rising CA-125 against CT scan confirmed the progressive disease. So do you consider role of surgery in platinum resistant disease, even if the disease is resectable? Dr. Abhishek?
Yes, ma'am. Yes, ma'am. If disease, though it is secondary cytoreductive, you are asking, ma'am.
No, the second, no, not in the platinum sensitive disease. The patient progressed after giving the platinum. It's a platinum refractory disease because it's
No,
been
ma'am.
less than.
No, ma'am.
No, okay, yeah. So I think we all agree on this point that there's no point of doing surgery in platinum refractory disease, even if it looks resectable. In some trial it was done, but the patient's profile is very, very restricted. It has to fulfill all the criteria. Next. Next. So this paper showed the benefit. Next. But again, we have to see the age, the albumin level, the performance status, and it should be done under the clinical trial setting only. Next. Okay, so in platinum refractory disease, these are the options to offer, mostly in the form of single agent chemotherapy. Then we have oral metronomic chemotherapy, and now if the disease is BRCA positive, then the PARP inhibitor, of course. Next. Next. So this is a use of paclitaxel weekly, even if we have used 3 weekly paclitaxel initially, either in the neoadjuvant or adjuvant, but we can give in the platinum refractory disease if we give it in a weekly form. Next. Yeah, so this is the data of giving pazopanib, another VEGF inhibitor, along with the oral metronomic therapy. Next. This is the TMS data done by the Dr. Seema Gulia madam. Again, the role of pazopanib and the oral cyclophosphamide in platinum-resistant ovarian cancer. The PFS benefit was there with the manageable toxicity. Next. Coming to case 2. So this is a 60 years old woman, PS1 with hypertension with extensive pelvic and peritoneal implants, ascites, and upper abdominal bulky disease. Ascitic fluid cytology revealed adenocarcinoma with raised CA-125, normal CEA which is 2.4. So case was discussed in MDT and planned for the neoadjuvant. So can we start on the chemotherapy based on ascitic fluid cytology, or is it mandatory to do biopsy in every case? Sir, Dr. Devesh, sir?
I think some in that scenario, if gross ascites, so I will make the block cytoblock
Okay.
for doing histopathology as well as the immunohistochemistry. So I think if my pathologist says that the block is also prepared and showing the adenocarcinoma, so on the basis of this report, I can start the neoadjuvant chemotherapy. But sometimes the material is not appropriate for future HRD, or sometimes BRCA can be done from the blood. So I think, in my view, ascitic fluid cytoblock is sufficient, but guidelines are saying the biopsy is recommended. I am still not comfortable with doing this biopsy if cytoblock material is appropriate.
Yes, I agree, sir, that we can start with the neoadjuvant first cycle. Later, the ascites, when settled, then we can later plan for the biopsy from either from the mass or any peritoneal or omental deposit. I think we all agree with this. Next. So, what are the absolute indication for the neoadjuvant chemotherapy? Dr. Abhishek, what do you think?
I think Dr. Abhishek is.
Dr. Abhishek?
Hello, hello.
What
Am I audible?
what do we follow in our clinics?
Yeah. If disease load is more and if there is a criteria for that inoperability, like root of mesenterism involved, pleural effusion is there, and all those criteria.
Yes, so either patient is not allowing us or the disease is not allowing us. Patient's condition, if PS is not good or if disease is extensive, we offer the neoadjuvant chemotherapy. Correct. Next. Next, please. Yeah, you can skip it. So these all we have discussed. The patient's point like poor performance status, poor nutrition status, low albumin. Next.
I think
You
just
can
want
skip
to
this.
interrupt. Yeah. So I think in ovarian cancer, most of the time we are using the neoadjuvant chemotherapy because surgeons
Okay.
are saying the disease is inoperable. I think in most of cases,
Yes, sir.
I think 80 to 90% we are using the neoadjuvant. Are you agree with Vinod? Vinod, you are agree?
Yes, sir. Sir, most of our patients are stage 3C4. So almost
Yeah.
I would say, sir, more than 95%. They are always neoadjuvant, sir.
Yes,
They
sir.
will be like coming on trolley with huge ascites, starting with weekly, packly, building up their nutrition. So most of the time it is like
But
Hello.
Yes,
Yes, sir.
I
but
I
agree.
agree.
sometimes surgeons are in so hurry so that they want to do even in do you still prefer the sometimes surgeon want to do everything wants so clear even in mild ascites. I think in my take in this ovarian cancer to give neoadjuvant chemotherapy irrespective of stage in all patient.
Generally we get in third stage, 70 to 80%, and advanced. So in
Okay.
those cases, it is advisable to give NSCT.
Okay. Okay.
Coming. Okay, can we
Sir,
continue, sir?
I'm in train, so my network may be some bit bad. Sorry for the
Yeah.
bad
No problem.
network.
So continue, Doctor. Continue.
Okay. So coming back to this case that we offer platinum paclitaxel and the carboplatin, 80 to 90% patient shows good response with this combination. But sometimes we get some patient where the response is not that great. Sometimes we find a stable disease on CT scan with some sort of serological response in form of decrease in the CA125. Then what do we do? Like in this case, the biopsy was not done, so they did the biopsy again. But what is your approach in clinics that after giving the neoadjuvant at least 3 to 4 cycle, even with that you're getting the stable disease? So what is your approach? Like doctor, we can discuss. Dr. Vinod, sir.
So I think 10% of the patient will have similar picture of a stable disease. So again, reconfirming the diagnosis, if the pathology, whether it is a WT1 positive ovarian cancer, clear cell carcinoma, they will respond poor, but they usually don't have so much of high CA125. We have to look again for like a gallbladder and stomach, whether primary was there or not. We can miss in early time. CA125 can be falsely high in these cases because of peritoneal involvement. So again, reconfirm your histopathology and you find all the same. Again, it is a bad one, high grade serous ovarian carcinoma. Then we usually continue with 3 more cycles of paclicarbo.
Yes, sir. Agreed. Totally. Okay. So after 6 cycle, if the disease looks resectable, we should offer it. Or I think preferably if we are in doubt, then surgery, like before doing the surgery, I think diagnostic lab can be done to confirm the resectability. Next. Next, please. We can move to next slide. Next, please. Next. Okay, so as we discussed, so what are the further options? So we need to give the palliative care and continue the same therapy for the 3 more cycle to attempt the surgery after the 6th cycle. Next. Okay, so rarely we find the progressive disease, also primary platinum refractory disease, though the percentage is very less. But do you think surgery can be offered there if disease is resectable? What do you think? What is your take on this point, sir, Dr. Devesh, sir?
Can consider for the surgery if we think the disease is progressive and platinum resistant. We can offer.
Yes, sir. I mean, that is surgeon's call again. So mostly they plan the diagnostic lab before doing this major surgery. Next. I think we can skip. Next. So this is the NCCN guideline showing the same.
Haram, please move fast.
Next, please. Okay, so I think mostly we have discussed because of
So
this topic.
anything remained? So we can take individual comments of yours, Vinod,
Yes.
and Abhishek and me.
Yes, sir. We can start with Dr. Vinod, sir.
So, sir, in my practice, usually most of patients are stage 3 and 4. PS is usually 2/3. We start with weekly peglycarbo. Most of the patient they become ready for surgery after 9 to 10 weeks of chemotherapy. Then we plan most of them interval debulking, then rest of the chemotherapy. Most of the patient I haven't found BRCA1 positive. Just recently, I had one patient that actually responded not very well with 3 cycles of chemotherapy, having lot of cytopenias, not tolerating paclitaxel and carboplatin, and she was having actually chylous ascites. So we went ahead with surgery, and during surgery, the resection was suboptimal, and whole of the liver was actually encapsulated in some like fibrinous structure. It was collapsed liver. Luckily, the report was PET-CR actually. Whatever the surgeon resected, it was no residual disease. So I tried for HRD. The initial block also actually was exhausted. Luckily, she is now, unluckily, she is BRCA2 positive. So when I went through literature, I found that these BRCA1 and 2 patients, they usually develop cytopenias more common during adjuvant and neoadjuvant chemotherapy. So now I have started her on olaparib because it was 3 months down the line from chemotherapy. So I started with low dose 200 mg BD because she tolerated very poorly chemotherapy also. So I hope that she do well. So this was my only case that came BRCA positive.
Okay. Yes, sir, Dr. Devesh, sir.
So, well, agree with Dr. Vinod. So, maintenance as a maintenance upfront, I have tried in 1 or 2 patient that comes to be positive after completion of this adjuvant treatment, offer the olaparib upfrontly for maintenance even in the higher stage of patient. So we can offer HRD or BRCA upfrontly. If comes to be positive, then olaparib maintenance can be added in this setting. Even in, I think more worried about this recurrent or relapse setting where options are exhausted as early as early. So I think 50% of patients are responding to bevacizumab or chemotherapy arms, following by the bevacizumab maintenance with endoxan or some types of the maintenance treatment. So few few patients work well with these regimes, but 50% of patients are progressing each and every regimes on this in this relapse setting. So I think 50% of patients are responding 2 to 3 years very well, but less than 50% of patients are responding very poor. So survival is 6 to 18 months, between 66 to 18 months.
Yes, sir.
So I think in my practice, BRCA can be offered to each and every patient upfrontly, germline first, followed by this HRD.
Yes, sir. So the major challenge is refractory disease, platinum refractory disease, where the options are limited. Because by that time, the PS is also deteriorates and we are not able to give the proper chemotherapy as well. Immunotherapy has not proved their role yet. Some ADCs, antibody drug conjugates, are coming up. They have shown the response. So let's wait for the results. I think by this, we can conclude this.
Yeah. Thank you,
Thank you.
Dr. Anu, for this
Thank you, sir. Thank you, Divesh sir. Thank you,
wonderful
Vinod sir.
moderation. Wonderful moderation. After my request, you have accepted.
Thank you. Yes, yes.
and
Some
thank Dr.
technical glitch
Vinod,
happened,
thank
but we'll
you,
take care
Abhishek,
next time.
No, not an issue, not an issue.
Thank
So,
Thank you, sir. Thank you, sir.
you will organize the conference. You will organize conference in Jodhpur, and I will, and
Sure.
we, Vinod and
Yeah, sure.
Abhishek will attend at Jodhpur.
Definitely, sir. I will invite. Yes, sir.
Thank you, sir. Good
Thank you,
night.
sir. Thank you, Dr.
Thank you,
Abhishek.
madam.
Thank you, Vinod sir. Thank you, sir.
Thank you, everyone.
Thank you. Good
Dr.
night.
Vinod is purely academic side, so I think we will benefited more and more by the Dr. Vinod in future also.
Yes.
So thank you, Vinod, thank you, Anu, and thank you,
Thank you,
Abhishek,
sir.
for this
Thank you.
discussion. And today we will conclude this the 2 days virtual webinar. So first day we discussed the breast as well as the GI session, and today is the first day on the lung as well as the GI, and today is the breast and GU session. So thank you all participants, faculties, and thank you all pharma companies for sponsoring this, and thank you Horizon team for supporting me. Thank you all and good night.
Thank you so much, sir. Thank you, everyone. Good night. Technical team, please close the meeting.
Yes.